It's a bright gray color. It has a fibrillar appearance, so as if there's the end of a broom sticking out from the picture, that's what it should look like. All these little fibers sticking out and pointing towards you. It should be sitting in the middle of the intertubercular groove. So if this is the lesser tuberosity and this is the greater tuberosity, here's the intertubercular groove with the biceps tendon in that area. And usually you're not going to see any fluid, but if you go down distally, sometimes there's a little bit of fluid on one side of the tendon, but it should not be all the way around the tendon, so it shouldn't circumnavigate the entire tendon. Now I'm going to talk about several biceps tendon disorders. One is tenosynovitis, another is tendinopathy, and then I'm going to talk about various tears in the tendon itself, and then I'll finish off with instability. So the first thing that I'm going to talk about is tenosynovitis. And I don't know, can we dim the lights just a touch? If we can, that would be wonderful, just because it lets the ultrasound pictures, you can see them a little bit better. But essentially, tenosynovitis is going to be dark or hypoechoic, and it's going to be circumferential around the tendon itself. And this could look like fluid, either simple fluid, which is anechoic or dark, or complex fluid, where it's got some particles in it. But the difference, and the way that you can tell the difference between synovial hypertrophy, or synovitis, versus fluid, is that fluid is going to be displaceable. So when you push on it, the fluid is going to flow away, it's going to go away. Whereas the synovium will just deform, but it'll stay in that area, so you'll still have that hypoechoic mass around the tendon. Another thing is that fluid is not going to have blood flow in it. So if you put Doppler on that area and you see blood flow inside of that hypoechoic area, then you know that's not fluid. That's got to be tissue in order to house blood vessels. It's going to be tender with tenosynovitis. So you can do sonopalpation, where you're gliding the transducer over the area, and where it hurts, it's going to be uncomfortable to direct pressure. And there might be associated fluid. So in addition to that synovial hypertrophy, you may have some fluid in that area. Now there are two main sources for fluid in the area. Thank you very much. One is going to be from the biceps tendon pathology. So in that case, it'll be tenosynovitis or tendinopathy or a tear. But sometimes you'll look at it and the tendon looks absolutely stone cold normal. And if there is fluid around the tendon, but the tendon is normal and it's not tender in that area, then that is going to be fluid from your glenohumeral joint, because the biceps tendon sheath is a recess for your glenohumeral joint. And so if you have fluid inside of your glenohumeral joint, you will see it in the biceps tendon sheath. And so that's an important thing to remember. It is part of the glenohumeral joint. So one of the things that can be a pitfall is determining whether there is fluid inside of the biceps tendon sheath, or might it be the subacromial subdeltoid bursa. So when you're looking at this picture, here's fluid sitting right over the top of the biceps tendon. But if you look, the biceps tendon itself does not have any fluid around it. And in fact, the transverse humeral ligament right here is separating the tendon from this fluid over the top of it. So your subacromial subdeltoid bursa, it protrudes over the anterior aspect of your shoulder. And so if you have fluid, often you'll have a thing called the teardrop sign, where fluid will pool down inside of the inside of the subacromial subdeltoid bursa over the top of your biceps tendon sheath. And that's going to look a lot different than fluid inside the biceps tendon sheath, where the biceps tendon is circumferentially surrounded by the fluid in that area. Now, something of note, if you see this and this in the same picture, so there's fluid around the biceps tendon, and there's fluid in the subacromial subdeltoid bursa, then 95% of the time you have a full thickness rotator cuff tear somewhere. So if you see fluid in the biceps tendon sheath and you see fluid in the subacromial subdeltoid bursa, really look carefully at your rotator cuff, because there's going to be a tear in that. So biceps tendinopathy is going to look similar to all tendinopathy. It's going to be enlarged, hypoechoic, rounded. It's going to be heterogeneous, so it's not the same echogenicity throughout. There are going to be some hyperechoic foci and some anechoic foci, but the whole thing will be relatively dark. And you may have associated intrasubstance tears, You might have increased blood flow inside of the tendon, and frequently you'll have associated tenosynovitis. So you might have thickened synovium around the outside of the biceps tendon as well. So if you look at this, normal biceps tendon, look at this giant hypoechoic biceps tendon. That's gotta hurt. So biceps tendinopathy can be predisposed to from a number of different factors. One is you might have a loose body. So here you can see this loose body that intermittently comes, I'm scanning back and forth across, right there, you can see it. So I'm just scanning back and forth across that biceps tendon in long axis. So if you remember, since this is a glenohumeral joint sheet, glenohumeral joint recess, if somebody has a loose body inside of their glenohumeral joint, it can pop up and go right down in that biceps tendon sheath. And then every time you move your arm, that biceps tendon runs against that little piece of bone, which hurts like crazy. The other thing is that people will often get hypertrophy and thickening of the cortex and irregularities in the cortex of the intertubercular groove. So it's almost like a saw. And again, every time you move your arm, that biceps tendon is running across those sharp edges, and that can predispose to tendinopathy, tears, and pain. So beyond tendinopathy, you can start moving into tears. And these tears can be partial thickness or intrasubstance, and they can be full thickness. So from a partial thickness standpoint, number one, they're almost always going to have associated tendinopathy. It is rare to have a tear if you don't have underlying tendinopathy. So look for the characteristic features of tendinopathy. And then two, look for an anechoic cleft. So you can see right here an anechoic cleft, or right here inside of a tendinopathic tendon. And the other thing you can have is a complete tear. So one of the characteristics of having a complete tear is an empty groove. Now, when you look at that groove, it almost looks like there's some tissue in that area. But if I start scanning right here, you can see how there is no tendon within that tendon sheath. I'm going to let that run through the video again. So it starts out in a second here, and right there it's dark, anechoic, so it was filled with fluid. And so absence of tendon in the bicipital groove is suggestive of a complete tear. Now I'll talk about a little pitfall on that as well in a second. But if you have an absent groove, an empty groove, then think about a tear. The big pitfalls are that you can have scar tissue in that area that mimics having a tendon, and that's why you have to scan up and down. The other thing is if you have a complete dislocation of your biceps tendon, then you're going to have an empty groove. And so you need to make sure that it's not just due to a biceps tendon dislocation, but in fact it's due to a full thickness tear. So a few things that you can do. Number one, look at the other side. If somebody has a hypoplastic or small biceps tendon, then typically on both sides it's going to be small. All right? Look medial. So if you have a biceps tendon, the dislocations almost always happen medially. So look medially. And then the other thing is look all the way down at the biceps, or excuse me, at the pectoralis major tendon. Identify your biceps tendon at that level, and then start to trace it more proximally. And if it's a tear, the tendon's going to discontinue. And if it's medially dislocated, then you'll see it, and it'll just move medially. So find it at that pec major tendon, and then trace it proximally. Now, one of the interesting things that I've also noticed clinically that I didn't put into this presentation is that if somebody has a chronic biceps tendon tear, of course they're going to have that Popeye sign, so they're going to have the nice big muscle. But the other thing is that as you're scanning down distally, normally the short head and the long head of the biceps muscles arise at that pectoralis major, where the pectoralis major tendon crosses over the top of them. But if you have a chronic tear of the long head of the biceps, then the muscle will drop down distally. So if you come down to that pec major tendon, you'll start seeing the short head of the biceps muscle, and you won't see a long head of the biceps muscle. And you keep scanning distally, 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 and then you'll see the long head of the biceps muscle quite a bit further distal. And not only will you see it further distal, but it'll be small and hyperechoic, because since it's not having any consistent pull on it, the muscle gets fibrofatty infiltrate and becomes atrophied. So it's small and hyperechoic and distal. And so that helps you determine that this is chronic and it's a long head of the biceps muscle tear. So Instability can be partial or incomplete. This is my biceps tendon. So medially here is the lesser tuberosity. This is the greater tuberosity, the intertubercular groove. And look at how that biceps tendon is riding up onto the lesser tuberosity. So you can see how that could predispose to developing tendinopathy in the area because it's going to be rubbing on that bony prominence. Or it can be complete. And so here we are tracing from down at that pectoralis major tendon, and I'm starting to glide up cephalad, and here's the biceps tendon, and it's moving more and more medial relative to the humerus. And here you can see the lesser tuberosity, the intertubercular groove, the greater tuberosity, and right here is that biceps tendon. So if I was just looking right here with my transducer, I wouldn't know whether that was a complete tear of my biceps tendon or a medial dislocation of the biceps. That's why you have to identify it distally and trace it up proximally. So again, typically it's medial, and it's often associated with one of two things. One is a shallow groove, so you just don't have as deep a groove, the greater and lesser tuberosities are not as prominent, or with a subscapularis tear, and this is really common. So if I'm looking at that greater tuberosity, or excuse me, the intertubercular groove, and the biceps tendon is gone because it's dislocated, medially, almost always there's going to be a subscapularis tear. And as you are all very aware, the rotator cuff tears away from the rotator interval. So essentially the rotator interval has your biceps tendon, the superior glenohumeral ligament, and the coracohumeral ligament. Those are the three things in the rotator interval. And more laterally is the supraspinatus, and more medially and inferiorly is the subscapularis. So tears in the rotator cuff start at that rotator interval, and in the supraspinatus they propagate posteriorly, and in the subscapularis they propagate inferiorly. So if you have a biceps tendon that is medially dislocated, always look at that cephalad portion of the subscapularis tendon right next to the bicipital groove, and you're gonna be a rock star because you're gonna find the thing that everybody else missed. So again, start at the pec major tendon, scan cephalad, always look medial. And if somebody has a normal looking biceps tendon, but they're tender in the area and they talk about a snap, then you always want to do dynamic scanning, where you have your transducer over that intertubercular groove, and then you externally rotate them and see if the biceps tendon dislocates medially as you externally rotate them. Then you can also do a Jurgensen's test, which again, you guys are probably all familiar with, where they do supination and elbow flexion and external rotation all at once, and you resist that, and so while they're doing that, the biceps tendon will dislocate medially. So you can have them do a Jurgensen's test while you're looking at the biceps tendon and see if it dislocates. So we'll move on to the supraspinatus, and what I'm going to talk about in the supraspinatus really works for all of your rotator cuff. So a normal rotator cuff tendon, or supraspinatus tendon, is going to be very hyperechoic or echogenic. So right here you can see how nice and hyperechoic it is. It's fibrillar, so it's rope-like. It's convex on its superior and inferior surfaces because it's running over the top of your humeral head. It tapers distally in the long axis, so as you come out, they call this the bird's beak, so you can see how it gets narrower as it comes out distally. In the short axis, again, it's hyperechoic or echogenic. It is almost like a tire on a rim, so if you think about the superior aspect of the humeral head being a rim of a wheel, then the tire of the wheel is going to be your rotator cuff tendon sitting on top of that rim. It should have very uniform thickness, and in general, a non-tendinopathic rotator cuff tendon is going to be 5 millimeters or less in thickness. If it's greater than 5 millimeters, then that's suggestive of tendinopathy. If it's much less than 4 or 5 millimeters, then you're starting to think about a tear. Deep to the supraspinatus, if you see an anechoic line, that is articular cartilage. And so that means you're looking at the intra-articular portion of that tendon. If you move further laterally, and I'm going to just go back one slide here. So right in this area, which is the long axis, if I have my transducer over this area and I'm looking at it in the short axis, I'm going to see articular cartilage deep to the rotator cuff tendon. But if I come out here and I look at it in short axis, so I have my transducer directly over this area, then I'm over the footprint where the supraspinatus is inserting onto the greater tuberosity. So deep to the greater tuberosity is going to be bone. So it will not be hypoechoic or anechoic. So depending on where you look at it, you'll either have cartilage deep to it or you'll have bone deep to it. And so that differentiates the footprint from the intra-articular portion. So the pathology that we're going to talk about, we'll talk about various rotator cuff tears, specifically partial thickness tears and full thickness tears. Then I'll talk about tendinopathy, and I'll split that up into standard tendinopathy as well as calcific tendinopathy. So the most common tear of the rotator cuff is a partial thickness articular surface tear in the anterior margin of the supraspinatus. So remember that the supraspinatus anteriorly, it's right next to that rotator interval. So it's right next to the biceps tendon. So if you're on the biceps tendon in long axis and you glide just a hair posterior to that and you see that anterior margin of the supraspinatus, that is where it is almost always torn. So that's where you have to put a lot of attention to in order to identify the most common tear. It's also pretty hard to see. What you'll see is typically a loss of fibers in that area. So right here, it can be hypoechoic or anechoic. Again, right here is an articular surface tear of those fibers. The superficial surface of the rotator cuff will remain convex unless it's a really high-grade partial thickness articular surface tear, and then you'll get a little dip in this area, so it'll become a little concave. But typically, you can see in both this picture and this picture, the superficial margin of the rotator cuff is remaining in a convex shape. One of the other interesting things that is a soft sign or a suggestive sign of a rotator cuff tear is a cortical irregularity. So you can see here, this is articular surface of the humeral head, and then right here is the footprint where the rotator cuff is attaching, and right there is this cortical irregularity. Right here is a cortical irregularity. So nice smooth bone, and then this little divot in the bone right here. If you see a cortical irregularity in the greater tuberosity, 75% of the time you have an associated rotator cuff tear. So just like having fluid in the subacromial subdeltoid bursa and in the glenohumeral joint, which is the biceps tendon sheath, that's 95% suggestive of a full thickness rotator cuff tear. If you have this cortical irregularity, 75% of the time you also have a rotator cuff tear. If there's no cortical irregularity, almost always there is no tear. So that's a really good thing to look for. If it's nice, smooth, bony surface, it's unlikely that that person has a tear. They may have tendinopathy, but unlikely that they have a tear. Another soft sign or indirect sign of a tear of the rotator cuff is the cartilage interface sign. And I'm going to show you a nice picture of that later on. But essentially, if you have an articular surface tear or a full thickness tear, then the sound waves will reflect off of the superficial surface of your articular cartilage. And it'll make that superficial surface of the articular cartilage white, as opposed to being dark. And so that is called the cartilage interface sign, and it suggests that there's a rotator cuff tear. You always want to document the dimensions. Now, the biggest pitfall of rotator cuff tears, and the shoulder is the most commonly scanned joint with ultrasound. And it's difficult because everything is curved. And the most common pitfall is anisotropy and miscalling a rotator cuff tear or tendinopathy when it's actually normal. So if I put my transducer right over here and I'm looking at the rotator cuff, this is what it looks like. So here's the supraspinatus coming out, and look at that. That looks like an articular surface tear of the supraspinatus, which is the most common tear of the supraspinatus. But if I move my transducer just down a little bit around the corner to try to make it so that my sound waves are hitting the fibers of that tendon perpendicular to their trajectory, this is what it looks like. So you can see how just tilting my transducer a little bit or changing the position makes it go from having a tear to being stone cold normal. So this is an artifact that you absolutely, positively have to eliminate in order to identify rotator cuff tears with a high degree of sensitivity and specificity. So just remember that. Partial thickness bursal surface tears are a little bit different than the articular surface tears. They aren't as common, but they're way more painful, and it's because your bursa is highly innervated, and so it hurts like crazy. In general, they'll have a loss of convexity because you lose the fibers on the superficial surface, so it will dip in. The other thing is that you'll frequently get bursopathy at the same time. So you might get thickened bursal tissue, or you'll get fluid collection within the bursa. So here you can see a fluid collection within the bursa, and this is that teardrop sign that I was talking about. We don't happen to be over the biceps tendon, but this is a fluid collection within the subacromial subdeltoid bursa. Here's the supraspinatus tendon. Here is fluid within the subacromial subdeltoid bursa. So just be aware of that and document the dimensions of your tear. And I'll talk to you a little bit more about that in a second. So one of the pitfalls that can happen, particularly on these bursal surface partial thickness tears, is you get bursal hypertrophy. And this hypertrophic bursal tissue will lay into the defect of the tear, and it'll mimic rotator cuff tendon. And so you look at it and it looks like there's tendon in that area, but in fact there's a tear. So there are some different things that you can do to try to get around that problem. So one is that the bursa extends beyond the greater tuberosity. So if this is the greater tuberosity right here, here's the supraspinatus, and here it is attaching to the greater tuberosity, the bursa will come over the top of the greater tuberosity and around to the corner, whereas the rotator cuff stays right on that greater tuberosity. So this is all bursal tissue up here, and this is supraspinatus right here. So just having them abduct will help you differentiate between bursal tissue and rotator cuff tissue. Very simple dynamic maneuver. Another thing is that bursal tissue is compressible, so you push on it and it squishes, whereas rotator cuff tissue is not compressible. It's very stiff, so when you push on it, it's not going to deform at all. The other thing you can do is if you look at an area and you're just not quite sure, is this bursal hypertrophy, is this a rotator cuff tear, what's going on in this area, do an injection into the subacromial subdeltoid bursa and just put some saline into that area. And when you do that, it will fill the rotator cuff tear defect. So right here is fluid from the subacromial subdeltoid bursa. This is a bursography, and that allows you to see this tear. It's the same picture. This is the same tear as this is. It's just that this one has fluid injected into the subacromial subdeltoid bursa. And you can see how much easier it is to see that tear if you inject fluid into the bursa. Full thickness rotator cuff tears, the primary sign is that you have no fibers crossing that area, and it goes from the bursal surface all the way through to the articular surface. So it's a complete tear from the top to the bottom. But these can be focal, meaning they are a complete tear in one area, but they don't extend across the tendon in the anterior-posterior dimensions. So I'll talk about that a little bit in a second. So they can be a focal defect or a complete tear. But there are all those secondary signs that we talked about before that are suggestive of rotator cuff tears. So glenohumeral joint effusion, fluid in the biceps tendon sheath, along with subacromial subdeltoid bursal fluid, 95% suggestive of a full thickness tear. The cartilage interface sign, which is beautifully depicted right there. See how hyperechoic that surface of the articular cartilage is? So that is the cartilage interface sign. Volume loss, so loss of the normal volume of fibers, and then the cortical irregularities that we talked about. Now with the measurements, you want to do measurements in two different angles. So number one, you want to measure from medial to lateral, so that's in the short axis, so how far anterior and how far posterior, so anterior posterior is in the short axis, so how far anteriorly does it go and how far posteriorly does it go, and so that's the cross-sectional area of the tear. And then in the long axis, which is medial lateral, so that's in the long axis with your transducer. So how much has it retracted and pulled away from the greater tuberosity? So here is a long axis measurement. The rotator cuff, which is here, should be pulled out and attached to the greater tuberosity right here. It's a full thickness tear in this area, and the tendon has pulled back to here. So you want to measure the distance between these two areas. Then you flip it into the short axis and you see how wide that tear is. So typically we want to do this in relation to the biceps tendon. So if here's the biceps tendon, then the supraspinatus sits just posterior to that biceps tendon. So you should see supraspinatus from here extending back in this direction in the short axis. And this person has some fibers intact anteriorly here, and then it has they have a defect right here. So if I was measuring this, I would say there is a full thickness defect in the supraspinatus located, let's just say it's 5 millimeters posterior to the margin of the biceps tendon, measuring 8 millimeters in the anterior posterior dimension, with retraction of 12 millimeters in the medial lateral dimensions. So that gives you all the information that you would need to know, and when a surgeon went in there to do surgery, they'd be able to identify that with assurance. Now, one of the things that's interesting is the supraspinatus, if you measure from the biceps tendon posteriorly, the first portion, the first 1.5 centimeters of this is going to be pure supraspinatus. But then, remember that the rotator cuff is a blending of all of these tendons. And so then you have the supraspinatus infraspinatus overlap, which goes from about 1.5 centimeters back from your biceps tendon to about 2.5 centimeters back from your biceps tendon. And that's the infraspinatus supraspinatus overlap. And beyond 2.5 centimeters, now you're into pure infraspinatus. So by doing those anterior posterior measurements, you can say what tendons are actually involved in this tear. The next thing that you want to do when you have a full thickness tear is look at the muscle. And this is really important prognostically because it tells you the age of the tear, and it tells you whether this is something that's possibly amenable to repair. So one of the things that we'll do is an extended field of view or panoramic view image. And so this is a short axis over the musculature of the supraspinatus, infraspinatus, and teres minor. Right here is the spine of the scapula. So this is anterior and this is posterior. So you take your transducer and you put it on top of the supraspinatus area, and then you just run it posteriorly, and it gives this nice long panoramic view. And this is in the normal side. So you have a nice big supraspinatus muscle, nice big infraspinatus, and teres minor. Normally the infraspinatus should be about twice the size of the teres minor. Now on the affected side, here's the teres minor, here's the infraspinatus, and then there's this teeny little supraspinatus. So that means that this person had a full thickness tear of their supraspinatus, and they have significant retraction, but now they have atrophy of the musculature, and they have fibrofatty infiltration in that area. And what that means is that if you repair that, it is going to be a non-functional supraspinatus tendon, and very likely they're going to have, the tendon is going to be so thin that the repair is just going to re-tear. And so that's a person that should definitely just have rehabilitation and should not go to surgery. So what are some pitfalls with full thickness tears? Well, number one, bursal hypertrophy. We already talked about that. The bursa can fill in an area. So if you look at this, here is what looks like the supraspinatus tendon coming across where it should be attaching to the greater tuberosity. But this is all bursal hypertrophy. Look at the cartilage interface sign right in this area. This is compressible when I'm pushing on it. If I did a bursography, you would see it fill with fluid in that area. So this is all bursal hypertrophy, but you can see how you can easily get fooled that that is an intact rotator cuff that's just tendinopathic. So use all those tricks I talked about before, the abduction, the compression, the bursography with fluid, to try to figure out, is this bursal hypertrophy or is this tendinopathy, right? The other thing is looking to see if they have a tear, and you only look at one area of the rotator cuff. So in this case, here's supraspinatus coming out around, here's attaching to the greater tuberosity, and you can see how it looks like, well, this is a tendinopathic tendon, it's heterogeneous, it's a little hypoechoic, but it's intact. So if you did that scan, and you told your surgeon or your colleagues, oh yeah, it's an intact tendinopathic tendon, but everything's good. But then the next person says, I don't agree with you. I think I'm going to scan it. And they scan a little bit back. Oh boy, full thickness tear right there. Make sure that if you're going to scan the entire thing. Don't just look at one area and think that you have diagnosed the problem. Make sure you look at the entire thing. so that you're not the person who missed that big full thickness tear. Tendinosis, I talked about this before. Normally the tendon should be hyperechoic and fibrillar. It should be less than 5 millimeters thick. Now, if it's thickened, so greater than 5 millimeters, hypoechoic, so it has relatively indistinct margins, it's dark, it doesn't have the normal fibrillar texture, it's more heterogeneous, all of that is suggestive of tendinopathy. You may or may not have any cortical irregularities, but if you do have cortical irregularities, then you're looking for a tear. That's not going to be just tendinopathy, that's looking for a tear in that tendinopathic tendon. The other thing is that it's very commonly associated with bursitis. Now I'll talk briefly about calcific tendinopathy. Now I presented that nice case in the other room, but calcific tendinopathy is made up of hydroxyapatite crystals, and it's actually relatively common in the general asymptomatic population. So up to 20% of the people in this room right now have a calcification in their rotator cuff. Only 50% of the time when you have a calcification are there any symptoms associated with it. And when you do have symptoms, there are two main reasons. One is if you have a big rock sitting in your shoulder, and every time you start moving your shoulder up, that rock bangs into the bone and it pinches all the soft tissues in between the acromion and that rock, that's going to hurt. So that's mass effect. But that usually doesn't happen because most of the time the calcifications are small enough that that doesn't cause a mass effect. The more common thing is resorptive phase, or the inflammatory phase of calcific tendinopathy. Because calcific tendinopathy goes through 4 phases. It goes through a formative phase where you're starting to form the calcium, and then it goes through a calcific phase where it's a rock hard thing in there. Then it goes through an inflammatory phase where your body recognizes this heterotopic ossification and wants to get rid of it, so it creates this massive inflammatory response, and it starts to liquefy the calcification, and it hurts like crazy. Some people will actually spike a fever with it. It looks like they're infected because it hurts so bad and they have all of these systemic signs. But it's just this dramatic inflammatory phase. And then you have the post-acute phase where the calcification has resorbed, the tendon is going back to normal, and you don't even know that they had a calcification in that area. It's more common in the supraspinatus, but you can have them in the other rotator cuff tendons. As with any calcification, it's going to be hyperechoic. But that hyperechogenicity is variable. Sometimes it's like this, where you see the hyperechogenicity and you have posterior acoustic shadowing. So this has so much calcium that the sound waves can't get through it. This one also has enough calcium in it that the sound waves can't get through it. You'll see it in a second here when the video starts over. So you can see posterior acoustic shadowing. But this one, look at this. This is calcification right there. And look at when you're just moving the transducer back and forth, the calcification is wiggling around in there. So it's this fluid-filled sac right there. And that person, you know, you look at this looks like it hurts. This didn't hurt this person. We just happened to be scanning them and they had it. This person was dying of pain because they had this inflammatory phase calcific tendinopathy. So if it is more fluidy, you're typically going to be able to see through it, whereas if it's more like a rock, you're not going to be able to see it as well. And this is going to be much more amenable to a lavage and aspiration. So take-home points for the diagnostic aspect. So ultrasound can play a significant role in diagnosing shoulder pathology. You should use a very systematic approach to your diagnostic ultrasound examination. I do it the exact same way every single time. And you can think about it similar to a physical examination. If you're doing a knee examination and you do it the same every single time, you're not going to forget to look for meniscal pathology and medial collateral ligament pathology and quadriceps tendon pathology. And if you find something, then you expand your examination based on what you found. And you do the exact same thing with ultrasound. So biceps tendon, then subscapularis, then acromioclavicular joint, then infraspinatus, then teres minor, then posterior glenohumeral joint, then the spinoglenoid notch, then the supraspinatus, then the subacromial subdeltoid bursa. Every single time. That's how I do a shoulder examination. It's important to remember that when you're looking at the biceps tendon, that you always go far enough distal and you trace proximal in order to identify any instability or tears in that biceps tendon. Make sure you cover the entire anterior, posterior, and medial lateral dimensions of the rotator cuff so you don't get fooled and miss that rotator cuff tear. Be aware of that bursal hypertrophy and the fact that it can mimic a rotator cuff that's intact. And use your dynamic maneuvers to your advantage in order to identify different pathology. So now we're going to move over to the interventional portion of the lecture. And I'm going to talk about subacromial subdeltoid bursa injections, biceps tendon sheath injections, acromioclavicular joint injections, glenohumeral joint injections. The lavage and aspiration I'll be very brief on, but I'll talk to you a little bit more about the setup and how I actually do the procedure. And then we'll draw some conclusions on this. So when I do ultrasound guided procedures, number one, I want to make sure that I know why they were sent to me if they weren't my patient, and confirm what the pathology is and whether this procedure is right or not. If it's not, I'm going to call the referring physician and talk to them about why they may want this procedure and also what I have found on my examination. I want to evaluate for any contraindications. Do they have a localized infection in this area? Do they have something that blocks the ultrasound needle from being able to reach your target? So different contraindications. Ergonomics is really important. I always tell people doing ultrasound guided procedures is like trying to put a credit card over the top of a needle. So you have this teeny little thin beam. And if you're looking behind you at the screen, you've got your shot going on over here and the person's uncomfortable and so they're wiggling around, you're not going to be able to do it. Your neck's going to hurt. You can't keep your transducer over your needle. Make sure they're comfortable. Make sure you're comfortable. Have everything set up ergonomically. Make sure it's the right equipment or tool for the job. So if you're doing a transforaminal epidural injection, can you do that with ultrasound? Absolutely. Is it the right tool to do it? Absolutely not. You shouldn't be doing transforaminal epidural injections with ultrasound. And the reason is because you can't see intravascular uptake. And you could cause somebody to be a tetraplegic if you inject them intravascularly, or you can kill them. And so just because you can doesn't mean you should. Make sure you've got the right medications, optimize your image before the procedure, and use aseptic technique. So for a subacromial bursa injection, I have the patient in a sideline position with the injured shoulder up towards the ceiling. I have their arm in a neutral position so they're comfortable. I put the transducer in the scapular plane directly over the supraspinatus tendon. I think that's the easiest place to identify the subacromial subdeltoid bursa. And then I'm going to take my needle in a long axis or in plane relative to the transducer from lateral to medial, and I'm going to guide it into the subacromial subdeltoid bursa. So in this picture, here's the supraspinatus, here's the deltoid, and then there's this hyperechoic two lines right here with a hypoechoic line in between them. The hypoechoic line is the actual bursal lumen, whereas the hyperechoic lines on either side are peribursal fat. And so I want to aim my needle for that little hypoechoic line. So here's a needle going down, and right there it's going into that hypoechoic line and starting to inject into the subacromial subdeltoid bursa. So for the biceps tendon sheath, I'm going to have the person in a supine position, and I'm going to put their arm at their side with their palm up. I'm going to put my transducer over the anterior aspect of the shoulder, typically over the greater and lesser tuberosities at the intertubercular groove. I'm going to take my needle from a lateral to medial direction in plane relative to the transducer, and I'm going to guide it down over the top of that greater tuberosity into the intertubercular groove, and I'm going to just pop through the transverse humeral ligament and into the biceps tendon sheath. And when I inject, I should see fluid forming around the biceps tendon and creating a target sign. So the biceps tendon is in the center and the fluid is around it, and it creates a target sign. Now, one of the things to remember is that the ascending branch of the anterior humeral circumflex artery sits in the lateral aspect of that intertubercular groove. And so is somebody going to bleed out if you hit it? No. But if you do hit it, you're going to have an inflammatory response in that area. You're going to get blood in the biceps tendon sheath. You might get synovitis. And so you're going to be injuring the area that you're trying to treat. The acromioclavicular joint injection, there are 3 or 4 different ways of doing it. I'm going to show you one. It's actually not the one that I typically do now, but this is the one that we used to do, and it's the most common one that's taught. So we have the patient in a supine position. We have their arm in a neutral position, and we put the transducer over the top of the AC joint. Then we'll bring the needle in a short axis relative to the transducer in an anterior to posterior direction, and we use the walk down technique. to get the needle into the joint. So if this is the clavicle, so it's medial, and this is the acromion, so it's lateral, right here is the acromioclavicular joint. The first pass of the needle should be superficial, and then you gradually walk the needle down into the joint by doing a little bit of a deeper pass each time, and that way you can ensure that you got your needle into the acromioclavicular joint. The way I do this now is I find the AC joint with my transducer, and then I turn so if here's the AC joint and I've got my transducer over the top of it, then I rotate my transducer so I'm in long axis relative to the intra-articular portion, and I go in plane with the needle anterior to posterior. Now if somebody has a lot of arthritis, sometimes there's a lot of interdigitation between those bones and hypertrophy and all sorts of osteophytes and stuff, and so it can be a little bit more difficult. But I like to do everything I can in plane rather than out of plane. And so that's a nice technique. The glenohumeral joint, I have the patient in a side-lying position, so they would be facing me, laying on their uninjured side. And I put the transducer on the posterior aspect of their glenohumeral joint in an anatomic transverse plane. It essentially is in plane relative to the infraspinatus. And then I'm going to take the needle in plane relative to that transducer from lateral to medial, and I'm going to guide it into the posterior aspect of that glenohumeral joint. So here's the infraspinatus tendon and muscle. Here's the glenoid labrum right here. Here's the humeral head. And so here's how the needle is going to come down and tuck right underneath that labrum. So here you can see the needle tip going right into that posterior glenohumeral joint. I do typically use a curvilinear array transducer, and that's because often it's fairly deep. The other thing is that it's a steep needle angle. So if I have some of my, in a linear array transducer, all of the sound waves essentially are going down. Whereas if I use a curvilinear array transducer, some of the sound waves are going to be going out to the sides. So if I have a needle coming down fairly steep angle on this side, and I have some of my sound waves coming out like this, they're going to hit that needle perpendicular to its angle of incidence, so I'm going to eliminate needle anisotropy. I'm going to be able to see the needle better. Now, lavage and aspiration, this is the last thing I'm going to talk about. This requires a fair amount of stuff, so I'm going to scrub them off with a FloraPrep. I put a sterile transducer cover and sterile gel over the top of my transducer. I have one syringe that's filled with local anesthetic to anesthetize them, and I usually use a 25 gauge 2-inch needle. And then I'll have a syringe with a 19 gauge 2-inch needle or an 18 gauge 3.5-inch needle, depending on how deep it is. And then I'll have a number of syringes that have saline or sterile water in them. And then I have one syringe with some corticosteroid. So the patient, I will have them in a side-lying position, and I'll put my transducer directly over the top of the calcific deposit. And similar to doing the injection into the subacromial subdeltoid bursa, I'm going to go from a lateral to medial direction in a long axis relative to the transducer, and I'm going to guide the local anesthetic needle through the deltoid and right down to the surface of that calcification. Now with the local anesthetic needle, I actually am not going to put it inside of the calcification. I'm just going to go down to the surface of the calcification. Then I'm going to take it out, and I'm going to take the 19 gauge needle or the 18 gauge needle, and I'm going to guide it into the actual calcification. And then I'm going to start doing this pulsed lavage where I push in, and because the calcification is enclosed, as I push in, it'll start to expand the calcification, but it's inside of a cocoon, essentially, and so it'll expand, but then it's going to have higher pressure. So if I let go of the plunger, it's going to push back all the fluid right back into my syringe. So you push and you let go, and you push and you let go, and you push and you let go. So it's just this little pulsed lavage that you're doing. If you poke a bunch of holes into the calcification, then it becomes a sieve. So you push fluid in and it goes out everywhere. And you're not going to get any calcification coming back into your syringe. So one of the big keys is having a single needle hole penetrating into the calcification so that it stays as a nice sac and not a sieve. And that way, when you push the fluid in, it stays inside and it pushes right back out into your syringe. And you just keep doing it until no more calcification comes back out into your syringe. That's how you know you're done. After the procedure, I typically have them take it easy for a couple of weeks. And the main reason is that you had this calcification inside of that area. You just removed a big calcification and left a gap in their tendon. You created a rotator cuff tear. So you don't want to have them going out and doing normal activities when you just created a rotator cuff tear. You want to allow their body time to start healing that area. So for a couple of weeks, I have them take it nice and easy. They usually feel great, but they have a tear in that area. So after 2 weeks, they come back in, they're still feeling good. I start a gradual progressive rehabilitation program based on how they're doing, telling them that really it's over a month or two that they're getting back into their normal activities. So I am very careful with that area. So in conclusion, there are a lot of different ultrasound-guided procedures that can be done in the shoulder region, and they can provide significant therapeutic benefits for your patients. I follow a very standardized approach to my procedures. I want to be comfortable. I want my patient to be comfortable. I do use sterile techniques, so I scrub them off. I use sterile gloves. I have a sterile transducer cover. I don't want to get an infection. Some people use the no-touch technique. I'm not opposed to that, but if you get an infection, it's not a good thing. I make sure that it's the right tool for the job, so fluoro's better for some things, ultrasound's better for other things. I make sure that I optimize my image and I get my needle in the right place and I confirm its placement before I inject my injectate. And that is how I do ultrasound-guided procedures. Thank you very much.